Welcome to Georgia Memory Net's new monthly webinar series, GM Insights, Expert Clinical Insights in Dementia Care for Your Patients. Today is our very first session, and our topic is Lessons Learned from 10,000 Administrations of the Clock Drawing Test, or Cognition. And this is going to be presented by Dr. Loring and interviewed by Dr. Johnson, both from Emory University. Feel free to ask questions by unmuting yourself at any time during the presentation, or you can use the chat box. And please make sure that you fill out the evaluation survey at the end of today's session with the link or the QR code. Thank you all for joining, and I'll turn it over to Dr. Johnson.
Hey, thanks so much, Lori. Really appreciate everybody who signed up to be here. I'm going to walk you through just a couple of introductory slides to get us started. So these are disclosure statements. I don't believe that any of these disclosures have relevance to what we're going to be presenting about clock drawing. So my fascination with clock drawing started early in my clinical training. I'm an internist and geriatrician, and I always found mental status evaluation and cognitive evaluation for cognitive dysfunction to be really important in the patients that I saw, but I felt it really wasn't done all that often. And so these are really, really old data from Albert Su, published in 1991, that was just showing how great the clock drawing test was in terms of its properties. It had a really great likelihood ratio for an abnormal clock and a really good likelihood ratio for a normal clock, meaning that if you were suspicious or maybe not sure, and you had your pretest probability and you throw this into your Bayes theorem, multiply out the odds and the pretest probability, and you really, it turns out that the clock drawing test is really powerful. Now, all right, so these data are 31 years old, and I looked at, and they've done this about 10 years later and 10 years later and 10 years later, and maybe not as good as Albert Su found in 1991 and published, but the clock drawing test has really stood up very well, and it's a great test to reaffirm what you're thinking, or a test that can surprise you some way. The other thing about clock drawing that I found fascinating was how many times clock drawing is embedded in other instruments that we might use in the ambulatory setting and in primary care setting. So this is part of the clock drawing instruction, which clock drawing is used to distractor from your 3-item registration and 3-item recall in the mini cog. And so they spot you the circle in that one. Here's the St. Louis University mental status examination. Since I do some of my clinical practice in the VA, we use the slums a lot instead, really in place of the mini mental state exam. And I think Dr. Loring will tell us a little bit about some things that he's found out about the slums, useful tool. They give you the clock face, and they want you to put in hour markers and the time 10 minutes to 7 o'clock. And that instruction is printed right in front of you so you can see it as you're going. And then in the midst of the Montreal cognitive assessment, right at the top right, there's also a clock draw right there. And so the mini cog is a 2-point, and the clock draw here is a 3-point. And there's these points that are, normal, abnormal, and then there's 2-point scales and 3-point scales and 10-point scales. And so I thought, just like Malcolm Gladwell, that I would go to somebody who's done this 10,000 times or more and ask him to offer me some thoughts about what he likes and doesn't like about clock drawing. And so I'm going to stop sharing screen. I'll let Dr. Loring share screen. You may hear me call Dr. Loring David or Dr. Loring. I apologize for flipping back and forth in advance, Dr. Loring. But tell us about clock drawing.
First, can you see my presentation?
Yep, we're good. We can see your presentation, so we can hear you.
Great. Well, again, it's a pleasure to be here and chat about clock drawing. I'm a neuropsychologist, but this is not a neuropsych test. I kind of conceptually view it as kind of a bedside screening procedure. Neuropsych tests that we have, it's given the same way each place, lots of norms, it's scored up, and there's no confusion with respect to when you get a percentile, what it means. Like I said, this is more of a bedside screening procedure, and that means it's done differently. And I'm not here to argue for one version of scoring approach being better or worse than any other ones. And I'm going to actually try to emphasize the importance of taking a look at the clock drawing rather than just simply relying on whatever number you have, because it really provides rich qualitative information to help you better characterize and understand what a patient's cognitive impairments might be. the different approaches, like I said, I'm not going to talk about, but they're basically like the MoCA. You take a look at the circle, take a look at how the numbering is, and more or less take a look at the hands. Again, that's not what I'm going to be talking about particularly today.
I would just offer in response to what you just said is that I'm often one who's looking at the instructions for how to do these tests, and you can look at the MoCA instructions, and it's slightly different than clock drawing is as a freestanding tool. And if you look at the mini-cog, there are two ways that you can give the instructions and different demands on the patient, just as you said, David.
Right. So clock drawing at least became very popular in the early 1980s. And it was, despite my talking about neuropsychology, done by a neuropsychologist at the Boston VA named Edith Kaplan. You may be familiar with her name because she was involved with the development of the Boston Diagnostic Aphasia Examination. The cookie theft card is part of the NIH stroke scale characterization. She had both a command, which is the standard clock drawing, and a copy version that kind of helped tease out some of the conceptual versus perceptual aspects when you have a bad clock draw. A number of times have been used to set the hands or to set the time of the clock. We have popular 10 minutes past 11 and 20 minutes to 4. And these are important because you take a look, both of these times involve both hemifields. And there's a little bit of confusion with respect to the difference between the number that designate the hour and the minute placement. I started actually with 20 minutes to 4 and over time have switched to 10 past 11 as kind of a preferred approach. Also, when I give the instructions and I give it outside the context of the slums or the MoCA or anything else, I use that as a screening test that I can personally observe as part of my clinical interview. I give the instructions 3 parts. First, I ask them to draw a circle. Then I ask them to start numbering, but start with number 12 at the top and then go around 1, 2, 3, 4, 5, and so on. And then set the time to 10 past 11. And the reason that this is important to me is other approaches, a person will probably start with the circle, then start 12, 3, 6, and 9. And what this does is it provides an anchor to the patient that can compensate in part for some poor planning that I want to test with the clock, so they can go back and then fill in the numbers. And it decreases the likelihood that I'm going to find information that is clinically meaningful. So I try to keep them from using these anchors or the corners of 12, 3, 6, and 9. So the question I think everybody's interested in is, when you get a clock draw, is it normal or is it not normal? And I always like to play with my students and say, well, a lot of times you can rely on my rule of thumb is specifically, if my mom looked at this, would she say this was impaired or not impaired? I think we can pretty much agree that this is not a good clock, and my mom would agree that this is not a good clock and probably reflects some sort of a cognitive impairment that might be clinically meaningful. We get situations like this, though, where it's a little bit unclear. Here's a clock. I think most people would say it's not too bad. If I asked my mom, is it okay? I think she'd probably say yes, because 10 minutes after 11, that's kind of okay. Spacing's not horribly bad, but kind of what do we make about this being in the pedestal? It's certainly odd, and I would, if you'll indulge me a little bit, call this a soft neuropsychological finding. What I'm going to talk about and show some examples of today is kind of what I call error types of clinical interest. And these were described by the Kahn-Weiner citation that I have at the bottom of the slide. I'll go over some examples of all these, but I think the thing I want to emphasize to begin with is that these are not mutually exclusive categories. And in fact, one of the reasons the clock drawing is so sensitive to impairment is it relies on many different domains. So impairment in any sort of cognitive construct is going to result in an impaired performance level. So they're not mutually exclusive. And oftentimes there's more than one of these impairments that I'm going to show you that are present when we're taking a look at the clock drawing itself. The first one is stimulus-bound or more concrete responses, and these tend to be dominated or guided by a single stimulus. A lot of time it's pulled to a specific number, 10 or 11. These two can also be considered conceptual errors, which I'll also show you some examples of. But here's a nice example. Patient's told to set the clock to 10 minutes after 11. Well, the arrow is pointing at 11 and it's a little bit to the side, presumably reflecting 10 minutes past, but there's a draw to the stimulus, the number itself, that is demonstrated by this example. Here's kind of a fun one as well. 10 minutes after 11. Remember, there's a draw to the numbers that are being talked about. We have 11 and 10, both associated with the arrows, but the arrows, of course, are pointed in the wrong direction and not appropriately anchored at the center of the circle. Another type of kind of stimulus boundedness, I'll call it, is how the person anchors the numbers when they're going out and performing that task. You can see they start out 1, 2, 3, 4, 5. And what happens if this error is going to occur commonly around 6, as they start to go back up on the left side of the clock, they anchor it so that the orientation of the numbers are drawn and determined in part by their orientation to the clock themselves. So that's kind of a stimulus bounded response that we oftentimes will see. Now, this is one of my favorite ones. If you remember, I asked for the drawing to be done in 3 steps. And that's exactly what this patient did. Without saying anything, started with this circle, then immediately moved on and drew this on top of that circle and correctly put in the numbers. And remember, the numbers was the second thing I asked for. And then at the top, drew a 3rd circle, put the numbers in. I don't know if there's any interference in effect here since the circle overlaps, but then went ahead and put the numbers in incorrectly placed. But again, this was determined a very concrete interpretation of the task demands that were given to him.
I had an example that might fit into the concrete, where someone wrote the numeral 10 right after the numeral 11 when I said 10 after 11, and also somebody that I asked to check their work and they actually went by and physically put checks on the work. So
right. You know, conceptual errors can mean really a lot of things. You know, basically the meaning of some of the features of the clock aren't accurately represented or understood or placed accurately. Take a look at this clock. You know, this one, my mom might say this is okay, but clearly it's not, because we have, not even discounting this little bit of spatial numbering difference, 10 minutes after 11, you could argue is correct, I think. But the fact some of the aspects of the clock, the overall big meaningfulness is lost because these are not appropriately anchored at the center of the clock. Here's one back from the days when I was doing 20 minutes to 4. Numbers are okay. But when I say set the time, 24 p.m., and I also purposely, took me a while to evolve for this, but I try to say set the time rather than say have the hands placed, because it's kind of a higher order level of abstractions that's necessary in order to successfully execute my request. Here's one I think a little bit similar to what Ted was talking about. 11 o'clock, it's 11 o'clock. Here's one, and a couple of variations of this that we see from time to time. 10 minutes after 11, so we got the hands correct, but then rather than appropriately anchoring them where they should be at the center of the clock, they're just simply connected. And just as a fun aside, for those of you who still believe in projectives for personality assessment, I think he would have a Beck depression scale or a depression scale that's pretty close to 0, kind of with this happy face kind of fellow. This is kind of the similar or more specific type of error that we see. You know, 10 minutes after 11, we see the correct placements very nicely. But what do we also see? Well, rather than having the hands appropriately anchored in the center of the clock and then going up appropriately to the numbers, it's anchored by 12, kind of, I think, a conceptual perseveration, because 12 is emphasized by me as a place to start, as an important number. I also see variations from time to time where there's just simply a straight horizontal line connecting the 2 numbers, again, reflecting that absence of appropriate centering and grounding, as the hand should be in the center of the clock. Perseverations can take a number of interesting forms, perseveration in general is a very common feature of any sort of brain changes, brain disease, almost independent of its location. And it refers basically to the continued execution of a response or response style that continues beyond the time that should have been terminated and switched to something more appropriate. Probably the easiest way in demonstration is here. Did not start at 12, but started numbering 1, 2, 3, 4, 5. You can see there's a little bit of stimulus boundedness. So the numbers are all facing the circle itself, the outside, all correctly spaced. And when we no longer any space left, we're finished at 17 o'clock. Another one.
I have one just like this.
17 o'clock?
No, this one that just keeps going and going and going.
Going and going and going. Again, it starts the numbering, and this motor program or this number sequencing is so overlearned that once you kind of start the motor, it'll continue on and on and on until there's something that forces it to stop. So here it continues up to 58. But you can see this is a gentleman or ma'am, I don't recall which, that actually started with number 12 as requested. Another fun perseveration is this one. Very appropriately put number 12 as requested. And then since it's a clock, probably like my grandfather, it's time to put some Roman numerals in because that's what a real clock looks like. So we start 1, 2, 3. And I guess on one level, this is not so bad, but we start going outside the perimeter. We go up to 9 o'clock, which certainly wouldn't classify as an accurate response in any sort of Roman numeral system that I'm aware of or know how to handle. And then perseveration can sometimes refer to conceptual perseveration. So he was asked, I think he decided to draw a clock face, and goodness, this is a clock face, right? Or a bit of a hockey mask if you're a goalie, or lots of different things. I do think that this is clearly an example, however, that my mom would agree reflects some sort of brain abnormality that should be watched and does not really require any sort of formal scoring approach to get it accurately characterized. Now, by and large, the errors that I've talked about are not diagnostically specific, but one that you might start to think about it is some sort of hemispatial errors. And this is where the content or the reproductions appear really just to the right side of the figure, oftentimes associated or thought to be associated with right hemisphere stroke in the absence of any other information. So it starts with 12, 1, 2, 3, 4, 5, all good. What happened when he got to 5, and this happened many times, there's an overlearn. People know 6 goes at the bottom, so you realize you have this spatial error, suddenly jump to 6, make that self-correction, and then since the left hemispace doesn't exist in a meaningful way to this person, continue numbering all up until all the space is gone. Another example, I didn't catch this person before they put the anchors in, and that was all correct. But here's an example of where the anchors did not provide appropriate context to compensate for the deficits we have, because as soon as he started numbering 1, 2, 3, 4, 5, 6, all the way up to 12 and stop. Again, this reflected a spatial inattention associated with a right brain stroke. Planning deficits are the things that are most common in subtler sorts of cases, and it's observed by taking a look at the number spacing. It's the most direct example here is a nice person, just start numbering. When we get to 12, time to stop. Another example, 12, 1. Then for reasons I don't recall, started numbering by 2, 2, 4, 6. And again, with a previous slide, 6 is in the wrong place. Let me go back and put it in the right place. And then just continue numbering up the left side of the clock. But again, there's overlap here. We talked about hemispatial errors possibly reflecting, right brain stroke, but it might also reflect simply planning inefficiency. You can see starting at 12, putting the numbers in, get back to 12, it's time to stop numbering, right? So outside the context of any clinical information, exam, imaging, et cetera, this can certainly be characterized accurately, I think, either as a planning problem or reflecting hemispatial problems. Sometimes see non-specific spatial errors, and this is just where the spatial layout is wrong. Here's a circle, all well and good, put the numbers, 1, 2, 3, 4, 5, 6, 7, got down to the bottom of the circle, and then continued 8, 9, 10. I think surprisingly, looking at the slide, why you didn't go to 11 or 12, but this also kind of might reflect this overlearned counting that we have from 1 to 10, and 10 is kind of a self-terminating sort of end to any particular counting sequence. Another example, a little bit different, but kind of the same, I think. We have the numbers that go around, but they don't follow any sort of correct spatial patterning. And this is just kind of fun too to look at in terms of the bleeding and the incorporation of one concept into another, because although the numbers are going somewhat correctly, notice they are actually, it's 12 o'clock, 1 o'clock, 2 o'clock, and so on. So those numbers are presented kind of reflecting a little bit of that confusion that we sometimes see. Numbers outside of the clock, oftentimes seen. Here's another example I think that my mom would not necessarily be alarmed at if I asked her to give me a clinical impression. We see the numbers outside the clock, which is an abnormality. Little other abnormalities we see, not quite connecting to the center. And I see this from time to time where the hands themselves are kind of outlined broadly, and I don't really know quite what that means, although it's always fun to speculate that it might mean something more meaningful than perhaps it really is. And finally, the last type of error that I have to share with you today is just simply numbers outside the clock. See this oftentimes? Here's another example of numbers outside the clock. I do want to draw your attention to another feature of this clock. I talked about these largely not being diagnostic in terms of any particular problem, but this, where the lines are drawn from the center of the clock to the numbers, I kind of call it the pizza clock, to me is seen oftentimes in patients with dementia with Lewy bodies. And I think it reflects both the combination of the spatial impairments that are common in those patient populations and also the frontal draw to particular stimulus field and perseverative type tendencies. And I did lie, I have one more example to share with you. It's just a simple counterclockwise, again, reflecting the absence of real knowledge or understanding of the relationship between number and placement and how that position should reflect a specific time. So real quick closing, I like it, it's quick, it's inexpensive. Things that, not to minimize it, it's really well tolerated. I'm a neuropsychologist, so a lot of my patients think my testing is painful. They can do this, they do it badly, it doesn't bother them so much and they move on to something else. Don't have time to talk about it, but there's no language confound. So I can give it to patients regardless of their language background. And it's really not really affected by education as well. And I think in conclusion, those qualitative features that we have are really rich and extend beyond any numbering system because you can kind of better understand the problems that they have. And although it doesn't happen too often, I've sometimes shown families clock drawings by their loved ones, and it can help convince them of the need to consider either additional workups or to restrict driving, because sometimes that's a difficult conversation to have with patients and families.
David, thanks so much. I had a couple of questions to ask you if it was okay.
Sure.
And so for folks who joined a little bit late, one of the things that you said early on was your 3-step instruction format for having people draw a clock. And you did some things that are a little bit different, and I see the logic of why you did it that way. So do you want to go over those 3 steps? First, you mentioned the circles, and then how you like them to do the numbers. And you don't say put the hands in. You said something different.
Right. So real quickly, each one is embedded in some other test. They have specific instructions on how to do it. Sometimes we have that circle actually drawn. Some approaches look at a drawn circle versus a freehand circle and so on. Screening tests by design are designed to have maximum sensitivity. So you're going to have more perhaps false positive errors. In the case for me as a neuropsychologist, we can refer on for greater workup. So I always have patients draw a circle first. That's step 1. The second step is to put the numbers in, but I want to increase the sensitivity to any sort of cognitive impairment. I don't let them go 12 3, 6, and 9, which can be done without any problem with, I think, most other screening approaches. By starting at the top with 12, they have to have that spatial image of where the numbers placement go. So they go 1, 2, 3, 4, 5 like that. And that allows the emergence with a greater likelihood of revealing a spatial planning deficit. That's a meaningful boo-boo for me. I think the last thing that Ted was talking about was, again, in the context of trying to maximize errors as a screening approach, is I have asked them to set the time to 10 past 11. Set the time. Some places say have the hands point and so on. I'm trying to take that cue away, making it as difficult in the sense of relying on the largest number of cognitive operations in order to successfully execute the task.
Thanks, David. That was super. I'm going to just show 2 slides on our way out, and Lori will help us monitor the chat for any questions that you have, and welcome you coming off of mute to ask questions as well. Just GM Insights is an outreach program to reach primary care providers and talk to them about different aspects of dementia care. And so Georgia MemoryNet is a statewide program dedicated to the early diagnosis and treatment of Alzheimer's disease and related dementias. And so we rely on referrals to memory assessment clinics in order to do this work. And just 2 thoughts about the role of what's going on in primary care. Certainly using the annual wellness visit as an opportunity to detect cognitive impairment. Welcome additional referrals in order to figure out what is going on and get an early and accurate diagnosis at one of our memory assessment clinics, at which time there's a handoff back to the primary care providers, including a detailed plan and connection with community services. Lori wants me to show you 2 additional things. One is that you can use this either QR code or you can link to that. And Lori, if you could you just put that in the chat, that link as well, but the QR code will allow you to go right through. If once you complete the evaluation, you are added to the sign-in sheet for CME credit. And if you need a bigger version of the QR code, there you go. I'll leave that up for just a second, and then I'll stop sharing screen. And we've got, Lori, thanks for putting that information about where to sign an evaluation and get your credit for CME. Questions, comments, thoughts? David, thanks again.
Well,
I have a question.
Yeah, go ahead, please.
Hi, my name is Becca. I'm a new nurse practitioner. Regarding the clock test, how do you see the efficacy of this test possibly decreasing over time, given that younger generations don't actually know how to read an analog clock and things are a lot more digitized?
Yeah, you're exactly right. You know, that comes up probably 5% of the time when I'm testing a patient. And I always think that's a good sign because they're aware of big picture items, but I don't know. I think it probably will. Unfortunately, I'll be retired by that time.
Hey, Google, what time is it? That's how I tell what time it is. And then the other thing, Stefka, to your point, is that there used to be a test that was commonly done called fill out a check register, where you would actually ledge and deduct the amount of your check from a running total. And so that's completely gone by the wayside. So yeah, that's a possibility if we're tired of looking at analog clocks. This may go away, but right now, still good according to David. So I appreciate that question. Other thoughts or questions?
That check drawing one, or the check one's a fun one because they always ask that in terms of managing a checkbook. And nowadays, most of the time is no need, no need. Just one final comment about Edith Kaplan. Yeah, she was a very famous neuropsychologist, like I said, from Boston. And she always argued that a neuropsychologist, and she really means anybody interested in cognition, should be able to do a thorough mental status evaluation on a beach with just the finger in their sand. And that kind of reflects why she has all these interesting clock drawings and all this sorts of interesting errors that we kind of took a tour through today.
David, you have more clocks than anybody that I've met. I know that people know that I'm interested in clocks. And so oftentimes in clinic, they'll like, hey, I got this clock. I made a copy of it. And so I do have a clock collection, but Thanks for walking us through. I have individual clocks, but you have a whole library, and I really appreciate you walking us through this. It'll be very valuable. Tell a friend that you can find this material online, and you can still get CME credit if you watch it remotely. And thanks so much. I'm going to turn it back to you, Lori, for any final words before we go out.
Just want to say thank you, Dr. Loring and Dr. Johnson, for presenting today. And thank you all for joining. And we hope to see you in our future sessions once a month, the third Wednesday of the month at noon. Thank you.
Thanks.